Okay, so we're going to start talking about mechanical ventilation. This can be a difficult concept to grasp, but I promise we're going to go through it, via the PowerPoint. And then if you need any additional support or explanations of things, you have my office hours. Feel free to contact me to set something up. Our learning objectives for the lesson. And then we're going to talk about our patient case study here. So we've got our 73-year-old female patient, respiratory rates 30 breaths per minute, accessory muscles to breathe, heart rate, BP, pulse ox, on room air, temperature, lung sounds. So looking at the cues in this assessment, so we could see that she's tachypnic, she's tachycardic, she's hypertensive, she's hypoxic, 82% on 21%, which is our room air. She is afebrile, but she does have bilateral crackles in her lung bases, so potentially some pneumonia. So immediate concern, we're going to jump right into airway, breathing, circulation. We also want to know where those accessory muscles are, like which accessory muscles she is using to breathe. So that's important data. And then our goal is to, at this point, get that oxygen saturation up. So looking at our orders, we've got stat ABGs, we've got the results. So looking at how we would interpret this, so let's go ahead and break it down. So our pH is very acidic, it's less than 7.35. And when I say like very acidic, so it's kind of like my own mental way of remembering anything less than 7.3 is very acidic, and then anything greater than, 7.5 would be very basic. Just as kind of a mental note to see that this patient is severely decompensated. So we could see this is respiratory acidosis because our CO2 is 55, our O2 is low at 60, and then our HCO3 is normal at 25. So this is going to be uncompensated respiratory acidosis. Now, if our HCO3 was like 28 or 29 or something like that, above 26, then we would say it was partially compensated respiratory acidosis because at least we could see that the kidneys were doing something to kind of help out and buffer that. So we look at our placement of a tube into a trachea, so our ET tube, endotracheal tube. So this goes via the mouth past or nose, but you're going to typically see this mouth past the larynx. And then a tracheostomy could be done more permanent. However, tracheostomies can be reversible if for some reason we can't use the mouth. And this is done via the stoma in the neck. So our indications for this are going to be our upper airway obstruction, apnea, ineffective clearance of secretions, and respiratory distress. And then our very last one, I would see this very commonly, is inability to protect airway. So if your patient cannot sense and swallow their own secretions, or they're not able to eat, they have severe dysphagia or something along those lines, that's considered an inability to protect the airway. Or if they are in like a comatose or like a stupor type state, if they have like a Glasgow coma score less than 8, then they would consider that an inability to protect the airway. Another reason patient might have that is if they have any facial burns or any trauma to the face, because that swelling and the edema could block off the airway. So that again would be considered, upper airway obstruction and also inability to protect the airway. So looking at a picture of our ET tube, so we've got the tube cuff that's inflated. We've got the cuff balloon that is what's used to inflate the cuff. We've got the tip of the tube that this is going to be hooked up to the mechanical ventilator. And then it's just going to go ahead and sit in the throat. 2 weeks, your book says 2 weeks, although in the healthcare setting, the goal from the initial time the patient is intubated is extubation. You can see how this inflated cuff sitting in the trachea can do some damage after some time. Again, it's a foreign object, it's a risk for infection, and any pressure on tissue can cause some skin breakdown. So, we want the patient to be intubated for, as little length of time as possible. Okay, so looking at the type of equipment, if a patient needs to be on a mechanical ventilator, we're going to need, and typically your crash cart's great because it's got everything. We're going to need the ET tube itself. Size is going to be determined by the physician, and respiratory therapy is, also very helpful at this time. To kind of discuss what's required for the patient. Gyroscope is something that it's like a little camera that the physician will use to actually intubate the patient, and only physicians are allowed to intubate the patients. The nurses don't do this. Paramedics are able to, but they use a special type of equipment to do it. We want to make sure that we have a bag valve mask, with 100% oxygen to make sure that we're giving them 100% oxygen prior to the intubation. And then we're going to also need some medication. So we're going to need a sedative and a paralytic. So with our sedative, something like propofol or succinylcholine or something like that, or succinylcholine is your paralytic, excuse me, like etomidate is going to be like another one of your sedatives. It's like an anesthetic. We always want to sedate before we paralyze, because paralyzed patients can think, hear, feel, so we want to make sure that we sedate and then we paralyze. Reason being, because even a patient that's sedated will still fight. You will still fight if somebody's trying to put something down your trachea. It's your body's own natural defense mechanism towards that. So paralyzing those muscles, allows for a smoother intubation process. We're also going to need a end-tidal CO2 detector, and this detector basically, it changes color, depends on the manufacturer for what color it changes, and it notes the presence of exhaled CO2. So this is hooked up to the end of the ET tube, again, to make sure that once they're intubated that we're in the lungs. And then we're going to get a chest x-ray. So, x-rays should be standing by because we have to get a chest x-ray to confirm the tube location. So it should be right above where the lungs divide into those two bronchi. We don't want it going into one bronchi over the other, because then it's only going to be inflating that one lung. We kind of want it sitting right above so that it's, distributed equally for throughout both lungs. Just realized that I like talk a lot. I miss being in class where I can talk, but then you guys talk and it's not just me talking in my room that's 90 degrees with a broken fan. But moving on. So we've got maintaining correct tube placement. So it's very important. I'd mentioned before in a previous PowerPoint that these are very secure to the patient. So once the correct tube placement is verified, it's going to be secured to the patient's cheeks, and then it's going to be tied around the back of the neck. And then we're going to look at the exit mark on the ET tube. So there's numbers kind of similar to an NG tube, and we want to make sure we measure it at the lip. So then there's going to be a flow sheet to make sure that, anytime the ET tube is assessed and repositioned, that, we mark it on the sheet that it's, still at that area of the lip. If the tube does happen to become dislodged, and I should also mention that patients are restrained. At this point, bilateral wrist restraints are part of your intubation orders to make sure they don't accidentally pull the tube out. Even though when they are mechanically ventilated and intubated, they're going to be on a continuous sedative. Typically, not always, if the patient is already in a super comatose state where they're not responsive, they may not be on a sedative, but it's very frequent that they're put on a sedative. So but if the tube does become dislodged, we want to make sure we stay with the patient and maintain the airway. So we're going to be giving them breaths with the 100% O2 with that bag valve mask, calling for help immediately. Do not attempt to reinsert the tube. Just kind of, it's almost like a respiratory code type situation. So we want to make sure that the tube does stay patent, and you guys saw that it's kind of sitting in that trachea, so secretions are going to work their way around the tube and be inside the tube as well. However, this isn't the patient that you want to routinely suction, so there's not going to be orders Q2 hours, Q4 hours. It's only if the patient needs it. So if you start hearing that rhonchi, or if the high pressure alarm, which we'll talk about, is going off on the ventilator, or, if your patient just has copious secretions around the mouth, those are going to be indicators that we're going to go ahead and suction this patient. So open suction technique. So this is what you guys were taught in the second semester, and this is for a tracheostomy. So this is a sterile procedure. You use your sterile gloves, maintain sterility of the catheter. The closed suction technique is really nice, and I'm going to do a little video where I show you Fred, my mannequin head, that has a closed suction catheter hooked up. What's nice about this is that it's sterile in an enclosed plastic sleeve, and it's connected directly to the patient's ventilator circuit, meaning it's connected to that tubing, it stays connected to that tubing, and then the other end of it is actually hooked up to a suction canister, which is always on, because the catheter itself has an on-off, like, it's not really a button or a switch. You'll see it in the video, but so this way that the suction stays on at all times, and it's hooked up to this, which is off until you can turn it on to be able to use it. And then it prevents any like foreign bacteria or objects or anything from getting into the suction catheter during suctioning. It also decreases exposure to you as the nurse when suctioning this patient. So here's a nice picture of it. Here is so it says thumb control for suction over here at the bottom left. So this, if you turn it, it locks, and then that means it's off. And if you turn it again, that means it's open. However, it doesn't start suctioning until you actually push it. And then you would just kind of thread the catheter in through the ET tube, and then do your, just the same as you suction before, do your intermittent, removal of secretions. So complications, hypoxemia, we're sucking out all O2. And another nice thing is that the patient's ventilator is hooked up with the ability to just a button that says 100% O2. So when they're hooked up to that ventilator, all you have to do prior to suctioning, instead of having to hyperoxygenate 2 to 3 times with that bag valve mask, is just push that button, and it delivers them 100% oxygen through their ET tube, through the, via the ventilator, so that they're ready to go for suctioning. However, hypoxemia is still a risk. Bronchospasm, if we're touching that tracheal tissue with the catheter. It can also cause increased intracranial pressure, mucosal damage, because and this is the reason why we don't want to over suction a patient, because if we cause mucosal damage, it actually causes some edema and inflammation, which can cause more secretion. So we can actually do more damage, and kind of defeats the purpose of suctioning in the first place. And then some additional ones are bleeding, pain, infection. So when suctioning the patient, we want to use less than 120 millimeters of mercury. We want to make sure we're hyperoxygenating before and after, and we want to limit each pass to 10 seconds using that intermittent thumb control. Okay, so oral care. So we want to brush teeth BID. How we're going to brush them is we're going to be using the hydrogen peroxide or chlorhexidine oral rinse. The chlorhexidine oral rinse is great to prevent infection, because it has these bactericidal properties that we want to make sure that we're cleaning that mouth out really well, because if any of those infected secretions get down to that in the lungs, they could potentially get a pneumonia, which would be considered ventilator-associated pneumonia, and we don't want that to happen. Mouth moisturizers are going to help prevent dryness and ulcers from forming. Again, that chlorhexidine oral rinse is also going to prevent ulcers from forming. We want to make sure that we're suctioning, and then reposition and retape ET tube. So depending on what the orders are at the facility, that tube needs to be repositioned, BID or daily. And again, that's going to be something that's put on the flow sheet. We want to make sure it's not sitting in that right corner of the mouth, or that left corner in the mouth, or the middle of the mouth, potential to cause pressure ulcer there. So some strategies to manage thick secretions. We want to make sure we're giving them adequate hydration. Mobility is going to help. Supplemental humidification is provided via the ventilator. And then we don't want to ever put normal saline into the ET tube, because that can be harmful. It can cause pneumonia. That was like an old practice that they thought would help with loosening the secretions, and it did. But again, the complications were greater than the help that it gave. If infection is the cause for thick secretions, we want to give, the appropriate antibiotics. All of these things are going to help thin out those secretions. So here's some pictures of some complications of ET tubes that I found. So the top left here, I'm looking at that. That's an ulcer. It looks like from the ET tube that was left in the middle of the lip and not repositioned from the time the patient was intubated. So it just literally caused a deep ulcer. Top right, we can see there's ulcer formation, and there also looks like some candidiasis, that fungal infection. Fungus likes warm, dark, moist areas. So if that's just, tube being left there, and then improper oral care as well. The bottom picture, this one, was really scary to me. It's crazy. It's, most likely is a patient with ARDS that was left in a prone position, and you can see where the tube had been pushed up against his face and he wasn't repositioned, and it had caused a deep ulcer on his face from that. So high-low valve. So some facilities use these, some don't. I've seen ICUs. I've worked in ICUs that used them. I thought they were great, and then I've worked in ICUs where they hadn't begun to use them yet. Basically, it provides some continuous subglottal suctioning, and it's just, you can see it's hooked up to suction. And it's got continuous suction hooked up to it, kind of like the suction equipment. However, with this one, there's no on-off valve. It's just kind of hooked up to low continuous suction, and it basically just pulls any secretions back from that subglottic area where you're not going to get them with suctioning the ET tube, because you can see that only goes down the tube, and it's too far back into the throat to get it with oropharyngeal suctioning. So it's just one more, kind of preventative measure that we can use to prevent the patient from getting ventilator-associated pneumonia from secretions backing up and potentially going into the lungs. Okay, so moving on to mechanical ventilation. So indications for typically patients, they're intubated, they're put right onto a mechanical ventilator once placement is confirmed. Our indications are going to be apnea or impending inability to breathe, like a respiratory code situation, acute respiratory failure, severe hypoxia, or respiratory muscle fatigue. So if a patient, respiratory wise, we've talked about the levels of oxygenation and how moving up from, nasal cannula all the way to be putting on a BiPAP or CPAP. BiPAP and CPAP, are great. They're frequently used at night to help with sleep apnea. However, they allow you to give them a FiO2, so 50%, 60% FiO2, and they can be worn for 24 hours. However, if a patient is on a CPAP or a BiPAP continuously, you have to think about the comfort level, and are they going to be able to eat or drink, and if their respiratory rate is still hanging out at in the 30s. Chances are they're gonna develop some respiratory muscle fatigue. So at that point, it may be time to intubate the patient if they're not gonna be able to be weaned from that. And at the very bottom, it says maybe ethical decision to use or not. This essentially means that, if it's like end stage ARDS patient, and we know that, putting them on the ventilator, they're going to be on a long-term, mechanical ventilator. Some patients or patients' family members might, determine that they don't want intubation. And also with your DNI, your DNRs, DNI, some patients opt, if they do, end up in a code situation, they might want all the treatment, but do not intubate. Okay, so go ahead and watch this video. Okay, so we talked a little bit about this with ARDS, with some modes of positive pressure ventilation. So positive pressure ventilation, we've got a predetermined tidal volume. This is a volume ventilation, and that's described as being a VT. And this is a set amount of air that's delivered with each inspiration. Amount of pressure needed to deliver each breath varies, so it depends on like resistance factors of the lungs. But regardless of the pressure that the lungs are giving, the ventilator is still going to give that full volume ventilation that it's been set at to give. So tidal volume with each breath does not vary. With pressure ventilation, there's a predetermined peak inspiratory pressure. So the difference is once that pressure is reached, any additional air will spill over into the environment, which means that if that peak inspiratory pressure is met early, there might be a large amount of air spilled over into the environment. The patient got a small tidal volume. Or if that peak inspiratory pressure is met late, then maybe that they had gotten a greater tidal volume with that breath. Ultimately, it's the tidal volume that varies and not the not the pressure. We want to make sure that we're preventing hyper or hypoventilation because that peak inspiratory pressure keeps being met early. Patient might not be getting enough air. They might be being hypoventilated, and if that peak inspiratory pressure is met later, then we might actually be hyperventilating them. If the patient starts breathing out of synchrony with the ventilator, meaning that if they were sedated and they start to wake up, or they're in pain, or they're agitated, they might start breathing against the ventilator. And in that situation, if you're trying to breathe against something that's trying to push air into you, that pressure is going to be reached very quickly, and then the volume of gas that's delivered is going to be small, if any. So it's really important that we make sure, we call that bucking the vent or ventilator asynchrony. So we really want to make sure that we're monitoring the patient and monitoring their ABGs and their SaO2 and the ventilator itself to make sure that they are not being hypo or hyperventilated. Okay, so we have our case study patient. We're going to talk a little bit about the vent settings. So we've got a tidal volume of 500, FiO2 of 50, respiratory rate of 18, and a PEEP of 5. So our tidal volume, that's going to be 6 to 10 mLs per kilogram of air that's being given to our patient. So this is the volume of gas or air. It's not oxygen. I don't want you to confuse it with that. It's basically just air or gas that's given during each ventilator breath to inflate the lungs. Now your FiO2, that is your oxygen. So this is set at 50%. We talked about before how room air is 21%. And this is adjusted to maintain that PaO2, greater than 80, sometimes greater than 60, depending on, what the patient's situation is. And then also to keep that SaO2 greater than 90%, 92%, again, whatever is ordered by the physician. With our respiratory rate, so this is, our normal respiratory rate is going to be 12 to 20. With the ventilator, it's going to be 6 to 20. So it's just the rate, how many times the ventilator is delivering a breath per minute. And then lastly is our PEEP. So positive end expiratory pressure. So this is the pressure applied at the end of ventilator breaths. So normally our pressure is 0. It's atmospheric pressure. When you inhale, pressure then drops to 0 and exhalation naturally occurs. With a PEEP of 5, this is very standard. It's physiologic PEEP, meaning that, patients that are intubated are 99% of the time put on like a PEEP of 5, and it basically is just keeping those alveoli open at the end of expiration. It makes them that much more easier to inflate once the next ventilator breath is delivered. So especially helpful for patients that have atelectasis or decreased surfactant production. One thing I want you to keep in mind though, the greater the PEEP, the more difficult it's going to be to extubate, because they are going to have to wean that PEEP down, because again, the normal pressure is 0. So if it's a PEEP of 10 or a PEEP of 15, they need that much more support to keep those alveoli open. And this is very common to see in patients that have ARDS. Okay, so inspiratory to expiratory ratio, our standard is that 1 to 2. So for every 1 second of inhalation, there'll be 2 seconds of expiration. Inspiratory flow rate and time, told you don't worry about that. Sensitivity, so that's the amount of effort needed to generate a breath. So for patients that have a lot of difficulty, increased work of breathing, that sensitivity might be set lower so that it's picking up even the tiniest effort from the patient trying to take a breath. And the high pressure limit is similar to that peak inspiratory pressure, although the high pressure limit can be set lower than the peak inspiratory pressure, meaning it's kind of giving you like a warning, like, hey, like we're hitting high pressures here. Whereas that peak inspiratory pressure, when the ventilator is set to that mode, it literally will keep delivering tidal volume until it reaches that peak inspiratory pressure. Anything extra, once it hits that peak inspiratory pressure, any extra tidal volume that it's trying to deliver will just kind of spill over into the atmosphere and won't be given to the patient. Okay, so now we're going to talk about the different modes. With assist control ventilation, think that this is going to be, the highest level of care for a patient, because with this mode, it's delivering that preset tidal volume that we calculated at a preset prescribed rate. Okay, so that rate is typically between that 12 to 20. Your patients can breathe over the ventilator, meaning like if it's set at 12, and it's usually done in synchrony with the patient's own breathing pattern, but they can take extra breaths. They can take maybe 3 extra breaths to, equal a rate of 15. The thing is, though, each time they take a spontaneous breath, like each time they go to initiate a breath on their own, the ventilator will sense that and it will deliver the full tidal volume. That's the preset. So every additional breath that they take is fully supported. Okay, so risk for this is hyperventilation, because if your patient is starting to get better, they're taking their own breaths, they take a breath, it's going to deliver that full tidal volume in each breath. So think about you taking 15 deep, long breaths per minute. For some patients, this is needed. And then for other patients, they can become hyperventilated potentially with this. Another risk is that if it's too difficult for a patient to initiate a spontaneous breath, then they might only be breathing those 12 respiratory, whatever it's set at, but we're going to use that example of 12. They might only be getting the 12 breaths per minute. In those types of cases, we say the patient is riding the ventilator, meaning they're not doing any work on their own. And we don't want to see that. We want the patient to be able to be taking breaths on their own. So in that case, we would lower the sensitivity, or kind of fix whatever underlying condition is making the patient have that increased work of breathing. So our next ventilator mode is synchronized intermittent mandatory ventilation, so SIMV. So this delivers a preset tidal volume at a preset frequency, similar to the ACV, same in synchrony with the patient's breathing. However, when the patient does take spontaneous breaths on their own, which they're allowed to do, they're kind of on their own. The ventilator is not going to provide any support. So with those additional breaths, the patient's going to determine the inspiratory flow rate and time. They're going to determine the tidal volume, the inspiratory to expiratory ratio. That's all on the patient. So any additional breaths kind of go unsupported. This is also used really commonly for patients that are, maybe slightly more stable. And with this, it allows them to kind of breathe with the ventilator, and kind of do their own work of breathing a little bit more than ACV. It's risk for hypoventilation with this, because if your ventilator is set at 8 with the expectation that patient's going to breathe in between those ventilator breaths 8 times to equal a rate of 16, and they're not, and then say they're only breathing 2 extra times, or they're breathing 4 extra times, but they're not providing adequate depth. So in those situations, this patient could become hypoventilated. Okay, next is our pressure support ventilation. So with this type of mode, this is commonly used for like a weaning mode. And it's basically just giving them extra pressure to the airway. When your patient takes a breath, it just provides like a rapid flow of gas to kind of like a boost. But the patient does determine their rate, they determine their inspiratory length, and they determine their tidal volume. So patient is, for all intents and purposes, breathing on their own. This is just a little extra pressure given with each breath to kind of help keep those alveoli open. Excuse me. So For our Think, Pair, Share, again, when we do the discussion board, that'll be our time to kind of create some questions and, you know, expand on things that maybe are still a little unclear. So I encourage you to kind of look at this case study. I want you to pick out what are the red flags, and then, you know, from those, or patient cues, from those, what is the most important? Like, what do we need to intervene with immediately? And then when we resume class, I'll have questions related to this case study and kind of like an unfolding scenario to present to you guys to kind of help you work through an actual patient. Okay, so another mode that we're going to see used, this can be used invasively, you know, on an ET tube or non-invasively, is CPAP and BiPAP. So CPAP is a little bit more support. You know, with that continuous airway pressure, it's constantly blowing air into the patient, keeping those alveoli open. So it kind of mimics PEEP. So that PEEP never allows that pressure to drop to zero. CPAP is the same thing. Risks with CPAP and with all of the ventilator modes that we've talked about is any increased pressure in the chest impedes venous return because it kind of provides mechanical constriction to those blood vessels. So we want to, you know, be careful using CPAP in patients with myocardial compromise because sometimes they, you know, they won't be able to accommodate it. Another thing to worry about with CPAP is aspiration. So we want to make sure that we're not giving food or fluids, you know, when CPAP's being used because it can, you know, blow that into the lungs, causing aspiration pneumonia. BiPAP is our other mode. BiPAP provides the 2 levels of support. So it delivers continuous air on inhalation, but then it lowers that pressure so that the patient is able to exhale easier. Okay, so talking about our alarms, if you have a straw available, you can go ahead and kind of participate in this. Otherwise, I'm just going to kind of talk you through it. So picture, you know, you have a straw in your mouth and you're blowing out of the straw, but you're covering up half of the end of it. So there's a little bit of resistance that you're meeting, but you're still able to blow air through it. So that is normal. So that's what a ventilator wants to sense. Now, if you cover up the straw at the end completely and you try to blow air into it, you can kind of feel that you're meeting a lot of resistance, you're meeting a lot of pressure, and you're unable to get air through. So that is the high pressure limit alarm that will go off on your ventilator. So this could be internal, meaning that there's some resistance factors going on in the lungs themselves, or it could be some type of obstruction of the tubing. So very commonly we'll see thick secretions causing a high pressure limit. If the tubing is kinked, if your patient is waking up coming out of sedation, you know, they might start fighting the ventilator, coughing, you know, becoming agitated, moving around, biting the ET tube. All of those things will cause the high pressure limit to go off. So for low pressure limit, coming back to your straw, if you take your finger off the end of it completely and blow out of your straw, you'll find it's really easy to get air movement through there, almost too easy. So the ventilator senses that too as being a low pressure limit. So typically the most common cause for that is disconnection at the ET tube site. So if it's disconnected, it's not meeting any resistance factors in the lungs, the air just kind of freely moves through, it's going to send off your low pressure alarm. Also, if there's any leaks or you know, openings in the tubing anywhere on the ventilator tubing, that will set off your low pressure limit too. So those are really the only 2 alarms you need to be familiar with. For the rest of these, you know, it's definitely going to be a respiratory therapy type situation. So if there's ever a situation where the alarms are going off, or even with a high pressure or low pressure where, you know, you've done your interventions, you've checked the tubing, you know, for leaks, you've checked for secretions, you know, depending on the alarm, and there's still a problem, then you would contact respiratory therapy to come take a look. Okay, so looking at this question, we've got a patient on synchronized intermittent mandatory ventilation, so SIMV. So you've got to kind of look at it and think, okay, what does this mode do? What is it providing them? We see that their ABGs, 82 has dropped to 72. So looking at our answers here, so we'll go ahead and start with D. So pressure applied by PEEP is too high, needs to be adjusted to prevent atelectasis. So really PEEP helps prevent atelectasis. So if PEEP was high, it would actually be doing more work to prevent atelectasis. So we know it's not that. Tidal volume provided by the ventilator is too high, increasing the amount of CO2 being exhaled. So those are inversely related. So if the tidal volume provided by the ventilator is too high, it would actually be decreasing the amount of CO2. It actually would be causing the patient to be hyperventilated, which they are clearly not. Ventilator is creating high pressure, suppressing venous return and cardiac output. So a PEEP of 5 is pretty standard. That's your physiologic PEEP. It is going to suppress venous return and cardiac output. However, that's not going to cause their O2 to drop. So our best option is A. Patient's respiratory rate may be decreasing, lowering the oxygen content of the blood. Reason being, if you look at their mode, they're on that SIMV mode. So we know that, with that mode, it's only giving them a certain number of breaths per minute with the expectation that they're going to take their own spontaneous breaths. So if they're not taking their own spontaneous breaths and they're only getting the support from the ventilator, it's probably not going to be enough. So that's the most accurate response to why their PaO2 has dropped. Okay, so we'll go ahead, we'll take the Kahoot as a class once class resumes. So let's talk a little bit about complications. So we talked about the vessels being compressed and decreased venous return. Also causes decreased preload, decreased cardiac output, and decreased blood pressure. The higher the PEEP, the more the pressure that's left in the chest, continuous pressure, meaning it never drops to 0. So this, becomes more of a complication. We kind of touched on barotrauma, volutrauma when we talked about respiratory failure and ARDS. So barotrauma, too much pressure can cause a pneumo, and then volutrauma is too much tidal volume, which can cause, some alveolar fractures from being overdistended. Okay, so we talked about hypoventilation and hyperventilation. So hypoventilation is, a decreased number of breaths that are typically shallow in nature. So alveolar hypoventilation is where the alveoli are not getting enough oxygen. So this could be from SIMV use, where the patient is not taking enough spontaneous breaths of their own. This could be leakage of air around the ET tube cup or the tracheostomy cuff or disconnection. So we're looking for that low pressure alarm. Lung secretions or obstruction. Again, oxygen isn't getting in. So that would be causing your high pressure alarm, but can still cause hypoventilation. Or, low VQ ratio. So if there's a perfusion issue where we have them on the ventilator, the settings are appropriate, but there's not adequate blood flow or there's not adequate hemoglobin, that decreases the oxygen carrying capacity too. And also looking at the ventilation of the alveoli, if our inspiratory to expiratory ratio is too low, meaning that, well, I should say if it's like equal, like 1 to 1 as opposed to a 1 to 2, that patient isn't given that extra time to ventilate to get rid of that CO2. So that could potentially be an issue as well. So hyperventilation is a little bit more straightforward. So we know when patients hyperventilate, they're breathing out too much CO2, they're taking, rapid shallow breaths. So with this would be that rate, if that rate is set too high, or if our tidal volume is set too high. Patients with COPD are at risk too, because we want to make sure that we're not giving them too much oxygenation to decrease their respiratory drive. And then down here where it says determine cause of spontaneous hyperventilation, typically what could make a patient that's ventilated start breathing too fast or fighting the ventilator, what we call ventilator asynchrony. If they're in pain, if they're agitated, so we definitely want to look at their pulse ox, we want to check ABGs, and then if those look good and patients hyperventilating, we want to definitely address pain maybe increase pain medication or sedation per protocol. And a lot of things in the ICU are protocol. ICU nurses function with a lot of autonomy because they kind of have to. There's changes that could happen over a minute with a patient, so they need to have that flexibility to titrate these medications, whether it be sedation, pain management, or vasopressors, or even fluids in some circumstances. So you want to look, is the patient agitated? Are they in pain? And address that. Okay, so let's talk a little bit about ventilator-associated pneumonia. So, major complication of PPV. It is also considered a never event because it's a healthcare acquired infection. So patient comes in without pneumonia, they end up being intubated, they develop pneumonia 48 hours after. The hospital does have to eat that cost. So looking at the risk factors, so contaminated respiratory equipment. So it's really important that when we talked about ART lines, Swan GANs, the pressure monitoring setup, we changed that tubing every 96 hours. With respiratory equipment, we don't want to change that at all. We want them to have just that one set throughout the entire time that they're intubated. But we want to make sure that the hookup with that equipment is sterile. Inadequate hand washing, so we want a strict aseptic technique. Some environmental factors, if the patient's if they're immunocompromised. And then impaired cough, because if the secretions start building up and they kind of back up into the lungs, they can get an aspiration pneumonia from that. Also colonization of oral pharynx. So it's really important that we're providing, good mouth care with that chlorhexidine rinse. It's going to help prevent mouth ulcers, but also help prevent aspiration pneumonia, because any secretions that are sitting there in the back of the throat, it's a dark, moist area, it's warm, bacteria love that environment, so they will start to kind of proliferate if we don't get rid of those secretions. So we see a VAT bundle. So this again is kind of a protocol, meaning that once the patient's intubated, all of these orders are put into place. So we want to elevate the head of the bed at least 30 degrees, and this is 30 degrees with the patient boosted. If the patient's kind of slinking down in bed, elevating the head of the bed isn't really going to do any good. So we want to make sure they're boosted and up at 30 degrees. Daily sedation medication is where we kind of titrate down their sedatives, usually done, first thing in the morning, kind of wake them up a little bit, provide some clear communication, kind of get them to cough, maybe move around a little bit, and just kind of break up the monotony of, being continuously sedated, and kind of helps clear out their lungs a little bit. Peptic ulcer prophylaxis, so this helps decrease the amount of acid, prevent acid reflux. DVT, usually there's some movement associated with that, so turning the patient Q2, providing SCDs. They may also be on heparin. Daily oral care with chlorhexidine. This says daily, but what I've seen, most protocols require BID, and then no routine changes of the ventilator circuit tubing, as I mentioned. So complications of positive pressure ventilation, so sodium and water imbalance. So because of the hypotension, decreased cardiac return, your kidneys kind of pick up on that, and they secrete aldosterone retaining sodium. So with that, your patient might have some generalized body edema, that anasarca. It might just be trace and kind of bilaterally distributed. Also have some decreased urine output, some oliguria. They shouldn't have anuria, like no urine output, unless they have some underlying kidney problems, but definitely expected to see some decreased urine output. Neurologic, so impaired venous return and drainage, increased intracranial pressure is a risk. Also with suctioning, that increases the risk. So we want to make sure that their head of the bed is elevated and that their head is in alignment at all times. So our GI system, so decreased blood flow, that hypoperfusion to the GI, causes lots of problems. So causes some decreased peristalsis, which can lead to gastric dilation. Also causes, acid accumulation, which can lead to stress ulcers and GI bleeding, and then ultimately constipation as well. So stress also prophylaxis, so H2 receptor blockers, famotidine, proton pump inhibitors, so pantoprazole or Protonix is your drug of choice for that. And then we have your enteral nutrition that can kind of help that acid that's being produced, kind of gives it a job to kind of digest that enteral nutrition. We really want to start low with that on the rate of that tube feed and just kind of see how they're tolerating it. What we would expect to find is, tube feed solutions go in as a liquid and they typically come out as a liquid. So kind of like a tan colored liquid stool. That's normal for patients receiving the tube feed and kind of something that we would want to see to make sure that they're tolerating it. So talked about the gastric bowel dilation. So if your patient's not going to be receiving enteral nutrition, what you'll frequently see is an NG tube, or more commonly, or orogastric tube. So it's secured to the ET tube. And then that would be put on, like a low intermittent suction to kind of decompress the stomach, suck out any of that extra acid. We have to chart that too as output. So making sure that we're monitoring, whatever the decompression tube is taking out, and that the equipment used is your standard Salem sump for that. If we are providing enteral nutrition, then that tube that's being secured to the ET tube would be your small bore feeding tube. Decreased peristalsis can cause constipation, so we'll put the patient on a bowel regimen. So this can include stool softener, may include some type of laxative. If that doesn't work, then we'll look at, suppository, a rectal suppository, or lastly, like an enema if needed. So musculoskeletal system is at risk for a lot of skin breakdown, contractures, drop foot. These are things we all have to be aware of when caring for this patient that can't move on their own. So it's really important that provide adequate pain management and then good nutrition, high protein, high calorie. Once they are extubated, then we're going to try to get them up and moving. And this progressive, we're looking at, getting the patient to dangle, to sit up, to stand up, to take steps, and then to eventually maybe do some stairs. Definitely going to have PT and OT on board, do some passive range of motion exercises while the patient is intubated. We might have some types of equipment that we're going to use to prevent contractures. And if the equipment's not available, we'll do like hand towels, roll them, in the hands to kind of prevent the fingers from becoming contracted. And then definitely patients should be on Prafo boots, help prevent skin breakdown, and then also that foot drop that could potentially be permanent. So nursing interventions, it happens where patients accidentally unextubate themselves. So it's really important that we secure ET tube, kind of like when you did your trach suctioning and you held down that faceplate. Anytime you're repositioning, you're going to kind of secure that ET tube to make sure it doesn't become dislodged. Sedation and analgesia is ordered, and then soft wrist restraints. Okay, so for some psychosocial needs, so agitation and anxiety, we want to assess the cause. So it's a very stressful situation being intubated, but we want to make sure it's not related to oxygenation, since that could cause some agitation and anxiety. So looking at the pulse ox, checking ABGs, and then if it's not related to that, then we'll kind of deem it that it's related to the stress. So we want to make sure that we're providing good sedation and pain management. And then, there's a lot of physical and emotional stress due to the inability to speak, eat, move, or breathe. So clear communication, explanations of what you're doing and why, providing some reassurance, and then, assisting with ADLs. And then once a patient is extubated, it's going to take them some time to get back to baseline. Oftentimes, I've dealt with families that have this misconception that once their family member is extubated, they're going to, go right back to doing what they were doing before. And, that's not the case. That requires some time. It takes a lot out of you being in bed for a prolonged period of time. So we want to educate them that the fact that these ADLs have now become complicated, even just something, like transferring themselves, is extremely difficult, that this is normal, it's expected, and that we're going to provide, as much assistance to make sure that it becomes easier, and that they start, getting back to baseline. But it takes time. It takes time and effort on the patient's part. So ventilator disconnection, the most frequent site for disconnection is between the tracheal tube and adapter. We always want to make sure we keep the alarms on, because if that does become disconnected, they're not getting any oxygenation. So we want to make sure that we can intervene, as appropriately, depending on what type of alarm is going off. So from the moment the patient's admitted to the ICU, they should have a nutritional assessment done within 24 to 48 hours to kind of anticipate their nutrition needs. If we're not giving them enough nutrition, this can impair oxygen transport, decreases their protein, can prevent them from being successfully weaned. Inadequate nutrition also suppresses the immune system, and overall, decreases the speed of recovery. So it's important that we, have that completed to see how we're going to be able to best meet their needs. So patients that are intubated are, have a hypermetabolic state going on. So, we want to make sure that they're getting increased calories, increased protein. Either enteral nutrition is optimal. We always want to use the gut if possible. If not, then we can go ahead and, provide TPN if needed through a central line. Patients with an ET tube cannot eat. But with a tracheostomy, there's some types of cuffs, some types of tubes where they can eat. So it just kind of depends what they have going on. Immediately after a patient's extubated, they should have a swallow study done to see if they're able to take food and fluids PO. Okay, so we're going to talk about being weaned from the ventilator, and looking at the assessment piece for a patient that's ready to be weaned. We want to look at patient's appearance. We want to look at their vital signs. We want to look at their ABGs. Lungs should be reasonably clear upon auscultation. Chest X-ray should be clear, or essentially clear. We want to make sure that that they're going to be able to tolerate the weaning process and breathe on their own. So any underlying conditions that brought them there should be resolved, or be kind of in the process of being resolved. So pre-weaning assessment phase, respiratory therapy will do this. They're going to run a test on the patient to check their strength and then their endurance, and kind of give the okay whether the patient's ready to be weaned or not. In the pre-weaning phase from the nurse's end, we're going to assess the neurologic status, hemodynamics. We're going to look at the hemoglobin, hematocrit, fluid and electrolytes, acid-base balance, total protein, albumin. And then we're going to start kind of titrating down their sedation, not stopping it completely, because remember, we're still in the pre-weaning phase, but we want to titrate it down and see how they do. So we're going to be providing some communication about what we're doing, and have them follow some simple commands. We want them to maybe blink their eyes, squeeze my hands, those types of things, explaining that we're working on getting the tube out, and kind of go from there. If their heart rate goes up, their respiratory rate goes up, their blood pressure goes up, maybe at this point during the pre-weaning phase, then they wouldn't be a candidate, and we would turn their sedatives back up. But if they're able to follow these simple commands, they kind of understand what's happening, then we would consider that a pass for our piece of the pre-weaning phase. Also, again, listening to lungs, checking the chest X-ray. Okay, so if they pass during the pre-weaning phase, we can go ahead and move to the weaning phase. So with this, we do a spontaneous breathing trial. So for 30 minutes, patient, maybe is just on a pressure support mode, or, however the respiratory therapy or physician deem the ventilator mode, but it's just providing minimal support. We're watching them for those 30 minutes to make sure that they're able to breathe on their own. We want to give them at least 30 minutes because initially, as those sedatives continue to wear off, they might be a little bit weaker, but then after that 30 minutes, they should be able to, have an adequate rate, depth, and be able to oxygenate themselves appropriately. However, we don't want it to go over 2 hours because if during that time, we have to make a decision. Are they doing enough to meet the body's needs? Or are they struggling and they're becoming tired out, and they did good for that 30 minutes, but now we're an hour in and they're becoming weaker. So in those situations, we would put them back on support mode with the ventilator, be it ACV or SIMV, whatever they were on. And then the spontaneous awakening trial. So that at this point, we would stop all the sedatives because we want to make sure when they start breathing on their own that, there's no sedation going on, because we want them to be completely alert and awake and able to do as much as they can breathing wise. Okay, so it's important that patients are assessed for weaning. It's typically done minimally daily, sometimes multiple times a day. So let's say your patient, they do a weaning trial at 8 o'clock in the morning, and we'll say that they fail it, they're put back on the ventilator. If they start looking good, they might try that again around maybe noon that day or 11 o'clock in the morning. So it is important to rest the patient between the weaning trials, meaning that we have the sedatives back on, the ventilators providing full support, and then try again later on. And then obviously we're going to provide explanations regarding weaning, ongoing psychological support, not only to the patient, but the family members too. Family members can become very disappointed and discouraged when their intubated family member fails a weaning trial, but it's important that we educate them that the important thing is that we're trying. We're in the process of trying to wean them from the ventilator, and that just because they didn't do good for this first one doesn't mean that they won't be able to be extubated that day. It just means not at this time. So your patient does great during the pre-weaning. They pass the weaning phase. They're ready to be extubated. So we're going to hyperoxygenate with 100% O2, have suction available, loosen the ET taper holder. Respiratory therapy will typically deflate cuff and then remove the tube at peak of deep inspiration. So the patient takes a deep breath with that 100% oxygen, and then we'll start to go ahead and remove that tube, encouraging them to cough during the process, to cough out any secretions, prevent anything from falling back into the lungs. And then after that, we're going to provide supplemental O2. So sometimes this will just be in the form of a nasal cannula. Sometimes it will be a high flow nasal cannula with a humidifier. And then sometimes, we might have BiPAP being used just as kind of like a transition to supplemental O2. So it just depends on the patient's condition and what's going on.